and I will be presenting on dry run surgery the 3D way. There are certain surgical challenges in complex kyphoscoliosis deformity correction surgeries. And the majority of these challenges are due to the distortion of screw insertion landmarks and the dysplastic pedicles, making freehand pedicle screw placement challenging. The small corridors for work, the critical neurovascular neighborhood, little room for inaccuracy, and the lengthy and tedious procedures make deformity correction surgery very challenging, and this can lead to surgical errors in the placement of pedicle screw, which can lead to complications and affect patient outcomes. Technological advancements are needed to improve the accuracy of pedicle screw placement, to minimize complications of pedicle screw breach, to reduce the duration of surgery, and to reduce radiation exposure. Robotic guided surgery and intraoperative navigation greatly improve the accuracy. However, they are costly and not widely available. We hypothesized that 3D printed patient specific spine models are a feasible and cost effective alternate technology in the absence of robotic and navigation, and they can be used in virtual preoperative surgical planning in deformity correction, as well as preoperative dry run surgical simulators for guiding the placement of spinal pedicle screws. A 64 slice CT scan of the patient is taken, and the DICOM images are used to generate the 3D reconstructed model of the deformed spine, and the images are converted into an STL file and imported into the 3D printing machine. Using FDM 3D printed technology, patient-specific 3D printed models are manufactured. What we did differently were, in a previous experiment, we altered the inner cancellous component of the model so that the model will give an haptic feedback to the surgeon, similar to a human bone, and the screw placement, the tapping and drilling can be done on the model itself. The models are very good aids in delineating the intricate anatomy. As you can see, here is a case of a congenital kyphoscoliosis due to a posterior hemivertebra, where the screw insertion landmarks are dysplastic and distorted. You can see that there is a midline defect in the area of exposure, and these can be very easily identified using a 3D printed model. And here you can see that in this patient of congenital scoliosis, a previous diastem excision and detethering was done, and the dorsal defect can be seen clearly. So these enable the surgeon to approach the patient during surgical exposure in a very safe way. This is one another case of a complex kyphoscoliosis where the vertebrae were grossly rotated, and you can see that the neuroforamina are right in the posterior midline, where normally the surgeon will use the right diathermy to expose. And this is where the nerve roots also exit, and these models are very useful to identify these defects and go for a safe surgical approach. The surgical simulation is performed on the model just as we place a pedicle screw in the normal human bone, and a CT scan of the model is taken to analyze screw placement accuracy and pedicle breaches. The surgical strategy is revised as needed, and the model can be taken to the operating room and it can be used as an intraoperative guide. As soon as we take a CT scan of the model, we just remove the screws, pack the holes with bone wax, and use trackers or markers inside the screw holes, which serve as a guide for the surgeon. And the accuracy is somewhere between 0 to 5 degree cephalocaudal and mediolateral, and some amount of eyeballing is definitely involved. Here is a comparison of a CT scan of the model with the pedicle screw placed and the post-operative CT scan of the patient at the same level and at the same site where C7 pedicle screw was placed, and it shows a 95% replication of trajectory. The accuracy of replication is between 90 to 95%. A few case illustrations. This is a case of a neglected thoracolumbar congenital kyphoscoliosis due to a posterior posterolateral L1 fully segmented hemivertebra. The model was used to delineate the screw entry sites, and the screws were placed on the model, and all screws were placed safely, and L1 hemivertebra resection was done, and these are the outcomes. At 27 months follow-up, the patient had a good correction of the deformity and no neurological deficit. This is a very interesting case of a 8-year-old female who presented with congenital cervicothoracic scoliosis, and you can see that a model was generated and pedicle screws were placed on the model, and after placing the pedicle screws, a CT scan of the model was taken, and you can see that there is barely any room for error in the cervical and upper thoracic levels. And after removing the screws, the screw holes were packed with bone wax and trackers were placed in the holes. And this is a view from the top and from the sides. And the angulation was approximately 60 to 68 degrees. Normally, we angulate a cervical pedicle screw maximum to up to 45 to 50 degrees, but this was a very rare case. And intraoperatively also the same trajectory was adopted. And in the first stage, we did a resection of the C7 hemivertebra and did a correction of the cervicothoracic scoliosis. And in the second stage, we incorporated a growing rod construct to modulate the thoracic curves. And at 32 months follow-up, the patient is doing well. These are the pre and post-op clinical pictures. The patient had no critical breaches of the pedicle and no neurological deficit. A total of 11 cases of complex kyphoscoliosis were done using the 3D printed models, and we compared with a historic cohort of matched controls, and the mean operative time and blood loss were significantly less in the 3D printed groups, and pedicle breaches were assessed using Gertzbein-Robbins classification, and you can see that 92% of the screws were intrapedicular in the 3D printed group as against 86% in the non-3D printed group. More importantly, the number of critical breaches grade C, D, and E were reduced by 50%, and there were no neurological deficits in the 3D printed group as against 2 neurological deficits in the control group. And these visual analog scores and the SRS-22 scores were comparable in both the groups. More importantly, we did a cost-effective analysis, and as you can see, the mean additional cost incurred per surgery for the use of navigation ranged between 50,000 to 80,000 INR and even more for robotic surgery. Whereas the cost of making this model is only between 4,500 to 9,000 INR. This is the first study to use the models themselves as surgical simulators. Our study was comparable to previous studies. The accuracy of pedicle screw placement and the number of critical breaches were significantly less as compared to previous studies. And coming to the jigs, there are certain disadvantages of using 3D printed jigs. The accuracy depends on a meticulous soft tissue dissection and proper placement of the foot plate. And accuracy depends on the assistant holding the jig properly without moving during drilling or tapping. And jigs require a long manufacturing time, and the cost of manufacturing is also high, and it requires a great technical expertise to manufacture the jigs accurately. Use of 3D printed patient-specific spine models as preoperative surgical simulators for posterior only hemivertebral resection and for spine deformity correction surgeries enable better understanding and a 360-degree orientation of the spinal anatomy. It improves the accuracy of pedicle screw placement, reduces complications of pedicle screw misplacement, and shortens surgical duration and amount of blood loss during surgery. Thank you.